Secret hack number 4. So as a newbie, I feared the ortho physical exam. I felt that I always missed something. I had a favorite orthopedic physical exam book. It's a classic, but it was just so comprehensive. That's one of the books that I would read and reread, but it was so comprehensive that it was not practical for my 20-minute per patient visit follow-ups. So after asking and watching tons of times orthopedic surgeons perform their physical exams, I started to notice patterns, and their exams were very focused to the patient's complaint, and they were very quick. So with the right questions they asked during the history taking, they already had made a differential, and the exam basically just confirmed their suspicion. They knew what to do and how to elicit that positive finding. And the key basically here is to concentrate on what's important and to look for the common ortho presentations instead of the zebra ones. So I suggest not wasting time on a lot of these useless physical exam techniques from like the Stone Age, and actually concentrate on the ones that really matter. For example, I can do a comprehensive exam in less than 60 seconds. Sometimes I can do it in 30 seconds. And I know that so the key here is to know like the most common diagnoses and how to elicit that positive finding to confirm that on your physical exam, because this really is the goal for efficiency. So maybe some of you might be hesitant to think, okay, well, that's too short, right? Like it doesn't take 30 seconds, it doesn't take 60 seconds, but I want to show you how.
All right, so now we're going to try to do the knee exam in 30 seconds. You ready?
Ready?
All right. So let's begin. Make the leg straight. All right, the same thing. And bring it back. Now lay back on your back. Okay, this is the knee that hurts, right? So bend it all the way back. Okay, any pain around here? No pain?
Yeah.
Okay. Relax, relax, relax. And that's it. We're done with that knee.
All right. So let's move on to hack number 5. Order the right imaging. Many patients who came to our hip and knee ortho clinic came with an MRI report. Don't send a patient to the orthopedic surgeon with an MRI report. They need to see the images. When many times the orthopedic surgeon really wants to see initially the x-rays. So when they just need an x-ray, then the next question, right, is, well, what views do I get? So I get this question all the time, like what x-ray views do I order? Should I order an MRI with or without contrast? Is there an MRI something that I should do first line? But the answer is no, MRIs are not first line, x-rays are. So if you can remember something else and put it in your notes, remember that this is the most likely thing that you should do. First line, go to imaging for common ortho conditions, x-rays. Time doesn't really allow me to go through all of the different x-ray views that you need to order. So you can create a list of the right imaging views that you need to order when creating these common conditions, and that definitely will save you time. But luckily for you, I created the Ortho Imaging Black Book, so I can save you a lot of time with that, which is included when you get my When to Consult Ortho ebook. It's all there. It has all of the right imaging orders that you should get for each of the spine and extremity ortho common complaints. And I know that this is going to save you a lot of time. It actually saves me a lot of time because sometimes I forget like which one is the exact view that I have to order so that I can be able to either rule in or rule out this or that diagnoses. And you will also save your patient the frustration of going to the specialist just to be told that they never really had to go there in the first place because they don't really have disease, and it's coming from somewhere else, and you needed to work it up a little bit more. And this way your patient's going to be happy that you help them, and you also save them a copay money, time, from going to the specialist. So but yeah, that's really helpful. All right, secret hack number 6 is begin conservative treatment. Earlier, I told you that part of my job was to triage incoming orthopedic consults from PCPs. And it's sad to say, but I can't tell you how many patients were being referred before trying any conservative medical treatment. It seemed like the patient told the PCP, my knee hurts. And there was an immediate jerk reaction to say, okay, I'll send you to ortho. Whether or not you consult a specialist, you must have your patient trial conservative treatment. That is a must. So examples of conservative treatment include NSAIDs, if appropriate. Of course, make sure that the kidney functions are normal. Physical therapy for at least 6 to 8 weeks. Going to PT for 1 to 2 weeks doesn't mean the patient already tried it and exhausted. No, this is something that has to continue. Activity modification, injections also, and assistive devices. All these are things that can be done before referral. Many of these ortho conditions are chronic, and so remember to also is very important to manage your patient's expectations. That is also very key. Okay, secret hack number 7 is clinical decision making, using a clinical decision making tool. Since I became an NP, I've made it my goal to keep notes and use frameworks to improve the quality of the care that I provide for all my patients, and also for clinicians that sometimes ask me about ortho-related questions. And this has made my life easier and allowed me to get home on time, which to me has always been a main thing for me. Then I had the opportunity to develop an orthopedic consult pathway for PCPs from scratch, where I was able to apply all these ortho knowledge that I have. So the surgeons I worked with loved it because they would get patients who needed an ortho surgeon, and the PCPs consulting ortho also loved it because they would know when was the right time to consult ortho and when it wasn't, or if the patient needed more workup. And they were able to diagnose the patients appropriately. They ordered the right imaging because it was part of the pathway, and they also exhausted conservative treatment. So it basically was a win-win for everybody. And that is why I compiled all this information and created the When to Consult Ortho with Orthopedic Consult Checklist ebook for the most common ortho complaints in the outpatient setting. And I jumped there. And I've seen many of the NPs I've actually coached in the past have great success when using this tool. Most were brand new NPs, and the checklist just gave them confidence when consulting ortho. For me and those that I've taught, clinical decision-making tools have become a must-have. And tools like these will help you figure out if your patient can be treated medically with conservative management, or if an orthopedic consult is necessary. It's like a roadmap, that takes the guessing out of the equation. It took me years in the making. And just to give you an example, let's say that you have a patient with an ACL tear. Did you send this patient automatically to the orthopedic surgeon? Let's say that an MRI that you just happened to order picked that up. I mean, what do you do? Well, it depends. Is this ACL tear chronic? How old is your patient? Is this patient diabetic? And is the diabetes uncontrolled? Is this patient a smoker? How would the surgical optimization role will play here? These are all questions that need to be answered, and the answers for these questions will guide which path to take when it comes to consulting the patient out to, when it comes to consulting ortho and sending the patient over, right? So